to Tips 31 and 32, Treatment of Adolescents with Substance Use Disorders, brought to you by allceus.com. It's important to remember that adolescents are not little adults. Adolescent treatment requires an awareness of the developmental stages that the person is going through, as well as adolescent culture. Think about it. When we were growing up, or at least for most of us, the internet didn't exist, let alone text messaging and iPods and everything else. This is a vast change from what is currently available and what is currently mainstream culture for today's adolescents. So we need to understand how the internet and how technology and how all these other things and HIV and everything else has changed adolescent culture in order to most effectively work with adolescents. When we look at adolescent development, we first want to talk about cognitive issues. In early adolescence, we emphasize immediate reactions to behavior. The client may not be fully aware of the later consequences. They kind of live in the here and now and have difficulty forward thinking. Now we're talking your early teens here. In late adolescence, the person has a greater ability to use inductive and deductive reasoning and think about later consequences. Nevertheless, and there's a little caveat, that especially in substance use issues, we see that their developmental progress is often stunted wherever the addiction starts. So if their addiction starts in early adolescence, the person may actually not develop that ability to look into the future and anticipate future consequences before they act. Developmental tasks faced by adolescents include family independence. In early and late adolescence, they're testing the rejection of parental guidelines. They have some ambivalence about their wishes and about their parents' wishes. They have an insistence on independence and privacy and may overtly rebel. Most adolescents test limits, and some go into this kind of sulky withdrawal sort of phase. All of this is normal as they're trying to figure out who they are and what they stand for, etc. In early adolescence, most peers are of the same sex. In late adolescence, then you have the whole complication of dating and the need to please the peers over the need to please the parents, and risk-taking becomes a lot more prominent. When we talk about school and vocation, in early and late adolescence, clients are beginning to identify their skills and interests, and as they get older, they may start a part-time job. So they're identifying what they're good at. They're identifying what they can do and what they want to do for the rest of their life. They're also confronting the issues of, am I normal? Am I average? Am I worthwhile? They want to conform their behaviors to meet peer group values. Again, this is sort of rejecting the parental values, rejecting the parental mores, and conforming more with the peer group. As they progress into later adolescence, some continue to pursue peer group acceptance, and this is especially true if there's an extremely unstable family environment. And some are able to reject group pressure if it's not in their self-interest. So if the client is especially egocentric, they may even reject group pressure for their own self-satisfaction and their own self-interests. As a professional, we want to approach early adolescence with firm, direct support, basically sort of reparenting or acting as a third parent, conveying limits and simple, concrete choices. You don't want to align with parents, but you want to be an objective, caring adult. So again, you're presenting this parental type figure, but you don't want to side with the parents on everything. Present information to the child objectively about, okay, this is the situation, these are the choices, maybe even this is probably where your parents are coming from, and I see where you're coming from. Now let's talk about it. Encourage transference or hero worship. Encourage them to like you. Most of us who have worked with early adolescents have had the occasion where we've been in the grocery store or out somewhere, and one of our clients sees us and is like, "That's my therapist," announcing it to the entire world, which you kind of shrink because it's indoctrinated into us of anonymity and confidentiality, and this child has just announced to everybody and God that you're their therapist. Sexual decisions. You want to directly encourage the early adolescent to wait. Now, doing this without seeming like you're aligning with parents or being just kind of a stick in the mud is a very challenging line to walk. Again, provide them information. It's hard for the early adolescent to understand you're not emotionally ready for this, especially if you're working with an adolescent who has a history of promiscuity, a history of being abused, a history of being exploited, etc. You want to encourage parental presence in the clinic, but interview the early adolescent alone. So encourage the parents to be there for support, but they're in the waiting room. Some early adolescents and late adolescents will object to this too because they think the parents can hear through the doors. They think that the room is bugged. They think a myriad of different things. So you're going to need to weigh this, the costs and benefits of this with your client and see where they feel most comfortable and what's going to make them most comfortable. When you're working with late adolescents, be an objective sounding board, but let the adolescents solve their own problems. One of our key goals in working with late adolescents is telling them or helping them learn how to problem solve. Learn how to think, where do I want to be 6 months from now? Or will this really matter 6 months from now? Help them learn how to set incremental goals, incremental steps to get to wherever they want to be. Help them learn how to evaluate their actions and behaviors before they act based upon or based against their values. And so some of your counseling may involve working with them on values clarification. What do they believe in? What do they stand for? What do they want to represent? Negotiate choices. There are going to be things that have to be done. There are going to be decisions that have to be made. And you want to help negotiate these with the client instead of telling them, this is what's going to happen, that's what's going to happen. Give them the opportunity to earn privileges, to earn a reduction in treatment, to earn whatever. Be a role model, but don't get too much history. A lot of clients that, especially adolescents, that present for treatment have very vivid imaginations and can spin a very grandiose story. So get the idea, but you don't need to have great details. You don't need them going into this huge, long, involved story about everything. And then confront them gently about taking responsibility and the consequences of their actions. They're going to be making choices. They're going to be doing things out there, outside of treatment. As you review those in treatment, talk about the consequences. Talk about whether their behaviors were actually in alignment with their values, and if not, why they made that choice. You need to consider what gives them status in the eyes of their peers, because their peers are extremely influential at this point. And what takes away their status in the eyes of their peers? So what are the costs and benefits to each behavior? Use peer group sessions when possible. If you have the luxury of working in a facility where you have adolescent groups and you can get adolescents in peer groups, that's helpful. Adapt your systems to crises, walk-ins, impulsiveness, and testing. Now, testing we'll call both limit testing and psychological testing. But mainly you want to remember that the adolescent, again, not being just a little adult, doesn't have the same coping skills that a healthy adult would have. So when they're in crisis, they generally decompensate pretty darn fast. They need to be able to have access to emergency appointments. You need to prepare yourself that they may be impulsive. They may get up and walk out. They may be resistant. They may be sort of all over the place emotionally. Know how to handle those. Have methods in place if you're, for example, having a group session and one of your adolescents gets up and storms out. How do you handle that? Are you the only person? Is there someone who can attend to that adolescent? What needs to happen? Ensure their confidentiality. This is really tricky when you're doing groups because adolescents are notoriously mean to each other, both in and out of group. This is one of the things that brings a lot of them to treatment. So it's important in individual sessions to ensure confidentiality, to review confidentiality rules in group, to establish an element of trust, and to try to make sure that teens are able to freely communicate within treatment and go out, go to school, go do their daily activities, and not feel like they're all hanging out there blowing in the wind. And allow teens to seek care independently. Older teens, older adolescents, are not going to want mom and dad sitting in the waiting room. So if you can allow them to seek care independently, that's good. And you'll have to look at some of the legalities in your state about when you need parental consent, when you don't need parental consent, etc. Screening and assessment. The selection of instruments for use with teens is guided by the reliability and validity of the tool, its appropriateness to use on adolescents, the type of settings in which it was developed. For example, if something was developed and normed on a college freshman population, that's probably not going to be an appropriate instrument to use on a high school delinquent adolescent. And the intended purpose of the instrument. Was it intended? Was it designed to measure whatever you're trying to assess? Instruments need to be short in duration. They need to have high test-retest reliability. So if you give Jim Bob the same test 2 times without a whole lot of treatment in between, you should get similar results. There should be evidence of convergent validity. That means that if you give them one instrument that measures depression and you give them another instrument that measures depression, both instruments should give you pretty much the same information. Predictive validity. It needs to be able, if you're using one, to predict something in the future, like school performance, relapse potential, delinquency, etc. It needs to show that it's got validity to predict that. And when we talk about validity, especially if you're making major life choices, you want to look up around the 80% range, not down around 60%. If it's not much better than a 50-50 guess, what's the point in administering the instrument? The instrument needs to be normed on adolescents of that age group. So again, we've got early adolescents and late adolescents. Something that was normed on 11, 12, and 13-year-olds probably is not going to produce the same reliability and validity on 17, 18, 19-year-olds. And the test needs to have the ability to measure meaningful behavioral and attitudinal changes over time. So if you do it as a pre-test, post-test, ideally it can give you an idea of how well that person has progressed or where that person has progressed in their treatment. Family assessment is another important component in adolescent treatment, but we need to be very broad in how we define family. And this is true, again, I've said it before, for adolescents as well as anybody else. As society changes, our, quote, family is not necessarily our biological family of origin. And this is especially true in substance abuse populations. So we need to be open-minded and define family as those people who form the core social support for your client. The law and society may define family in ways that differ from the actual experiences of youth. Think about youth who are in the foster care system, or homeless youth, or children who are in families that are extremely dysfunctional, who spend most of their waking hours outside of school at a community center. It's important to also remember, when you're treating substance use in adolescents as well as anybody else, the core problem may reside outside of the person, and the substance use is a masking symptom. They're using it to numb some other major issue that's going on. They're being abused. They're being neglected. There's family substance use. There's something going on that they are trying to run from. They are trying to numb out, so to speak. Indicators that an adolescent should be screened include use during childhood or early adolescence. Now, if you haven't worked in substance abuse for a long time, or you haven't worked in the criminal justice system, it may shock you to hear that a lot of children around the age of 8 or 9 are already using marijuana, alcohol, anything they can get their hands on, but marijuana and alcohol are usually the two that are most readily available. Use before or during school. Now, unfortunately, we have this set of public service announcements on TV right now in our area that shows a kid going through a box of pills that he pulled from his parents' medicine cabinet. And the way it's presented almost sounds like a dare or a challenge, or, hey, by the way, you can get all the drugs you need from your parents. So I don't really like the way the messages are constructed. But it is important to know that youth aren't necessarily using illicit drugs. They may be using medications that they're gleaning from the medicine cabinets of their grandparents, their parents, their friends, whatever. Peer involvement in use, daily use of one or more substances, parental substance abuse, sudden changes in school performance, sudden marked changes in physical or mental health, engagement in risky activities, and truancy or running away. Any of these can indicate substance use. They can indicate the onset of a major mental health issue. They can also indicate family problems or the existence of abuse. So it's really important to differentially diagnose and to be open to changing your diagnosis. A lot of people, a lot of adolescents aren't going to come into your office and the first time they meet you go, oh yeah, my dad's been abusing me for the past 3 years. That's going to come up later. Deal with whatever is brought to you, and if you suspect abuse, inquire about it, and make sure that the child knows that there's a safe place that they can go. If you feel that there's reasonable suspicion of abuse that meets the definition required by mandatory reporting, then of course you've also got to follow up with a mandatory report. The goals of screening are to determine the severity of the disorder, examine associated factors, and make appropriate referrals. Give them direction. Give them beginning of a foundation from which to recover. Then you move on to assessment, which is more in depth than screening. So they go in for their screening, They've got problems. You give them hope. You help them increase their motivation, and you provide referrals to wraparound services to help them in other areas of their life. And then you refer them for full assessment. The assessment will document disorders and interactions of those disorders across all biopsychosocial domains. It identifies information to guide treatment planning, including strengths, social supports, and their motivation. We don't want to forget these. The adolescent has strengths already. The adolescent does have social supports. Now, whether they're the ones we would ideally choose or not, may be a whole other ballgame. Assessment also provides an opportunity for engagement and motivational enhancement, and is an ongoing process. As I said before, there are things that will come out later in treatment that weren't forthcoming in the initial assessment. So you need to be prepared and be aware of changes in your client's status and listen for them to tell you more information. Some things they may have intentionally withheld, some things they may have not thought were important, and they'll come up periodically throughout treatment. Areas for assessment include the substance abuse history, the age of first use for each drug, the frequency, intensity, and duration of use, and how it's progressed. So if they started drinking maybe on Fridays after school and, a couple of beers, and then it progressed to getting completely schnockered on Fridays after school, and then it progressed to drinking every single day after school, you can see a progression not only in the intensity, but also the frequency of use. Ask about concurrent use. Did they start just with alcohol and it progressed, then they added marijuana? Were they doing alcohol and marijuana concurrently? What was going on? What are the immediate and remote consequences of use? And when we think of consequences, usually we think of negative. But there are positive consequences. They wouldn't be using if there weren't positive consequences. So what did using get them? And what did it cost them? Ask about a family history of use for each substance. And discuss peer and family attitudes toward drug use. And this includes alcohol, prescription drugs, and illicit drugs. Talk to them about their personal mental health history as well as their family mental health history. Any present symptoms they're having, any past issues that they've had, how it's been treated, what worked, what didn't. What are their coping skills? How do they deal with stress? What are their strengths? What do they bring to the table that they can build on? Is there a history of trauma? Now, this can be abuse, but it also can be loss. There are a lot of things that cause grief and trauma. So talk to them a little bit about it. You don't want to press them too hard and precipitate a crisis, but you may need to define what trauma is. Losses, moves, anything major that has happened that has sort of devastated them. Assess their self-esteem. Where are they at? How do they feel about themselves? And can they internally validate, or do they rely exclusively on external validation? Do they rely on other people telling them that they're okay? Or can they tell themselves that I'm okay? And finally, assess for eating disorders. And this is true in males and females. Males have a really rapidly growing rate of eating disorders in the adolescent population as weight training and men's fitness magazines become even more popular. It's important to recognize the signs of eating disorders, especially bulimia, in males and females. Now, anorexia is likewise really important to recognize, but that tends to be easier to identify than bulimia. Most people with bulimia tend to be of average weight or slightly above. And that's the kicker. You don't, unless you start probing about it, may not identify it. And a lot of people, again, will not admit to purging behaviors in the first session, maybe not even in the first couple of months. So do be in tune to issues about if they're constantly talking about their weight, their appearance, dieting, whatever. Physical health, current and past issues, current medications they're taking, and this can even include over-the-counter medications like Benadryl for allergies, if they're having lots of migraines, if they're having lots of stomach problems. I mean, hopefully you don't have a teenager with ulcers, but it happens. Ask them about their family health history. And look at housing. Are they in safe, stable housing? Assess their school performance, attendance. Do they enjoy school? I'm sure there are parts of school that they really despise. Most of us did. What do they like about school? What don't they like about school? And assess for learning disabilities, especially if you've got a client who's presenting who has always had mediocre grades, who reports always struggling in school. If you have someone who was getting straight A's for the first 8 years and then all of a sudden starts flunking out, most likely it's not a learning disability, but if you see a consistent pattern of struggling in school, that may indicate that you need to take a look at a learning disability existing. Socially, evaluate their peer relationships, changes in peer groups, interpersonal skills, their neighborhood environment. What's it like when they go home? Gang involvement, pro-social activities, mentors and social supports. Ask them about their sexual history. How sexually active are they? What's their sexual orientation? And talk to them about STDs and pregnancies. Assess whether they have juvenile justice involvement and look for developmental milestones and events. Are they adequately achieving each of these? Now, they may not remember when they were potty trained, but look for, are they staying pretty much on task with progressing in school? Are they developing appropriate social relationships at appropriate ages, etc.? Look at their family history, including parental relationships, involvement with DCF, and the home environment. Are their parents both physically and emotionally present for them? Most likely not. Or there's some issue going on in the family. If you come from a family systems background, you tend to believe that the adolescent may be the identified patient. They may be acting out in order to divert attention away from another problem, in order to get attention because they feel forgotten about, because the parents are focused on other things. There's a lot of reasons that someone may present as an identified patient. Chances are there's something going on in the family that can be tuned up a little bit at the very least. And again, assess for their strengths. Talk with them about what makes them a good person. What makes them happy? What skills do they have? What do they enjoy? When you're constructing the integrated summary for adolescents, as well as for anybody else, you want to identify the severity of all disorders, the mitigating and exacerbating factors. For example, if you have co-occurring depression and substance abuse, as depression gets worse, that's an exacerbating factor generally for the substance abuse. So everything probably interacts with one another, but but there are also going to be external factors that mitigate or exacerbate the diagnosis. For example, the presence or absence of certain people in the person's life. Identify a corrective action plan to address the problem areas. Work with the client to identify and rank in importance the problems to address. Make sure the treatment plan is individualized, implemented, and monitored. Many adolescents cannot follow through on a long-term plan. They need somebody to keep them on task. So it's important to make sure that there's somebody there to check up on the treatment plan periodically. This doesn't mean they need day treatment. It does mean that they need structure and support. And the integrated summary will also make recommendations for referral linkages to other professionals, psychiatric, medical, dental, any myriad of resources that the child may need. It identifies a single point of contact. When you're making referrals, that's all well and good, but if nobody knows who to communicate with, the right hand's not going to know what the left hand is doing. So the integrated summary must identify a single point of contact and describe how resources and services of multiple agencies can best be coordinated and integrated. So you may put something in the integrated summary about you're making referrals to X person at X organization and Y person at Y organization, and each person will participate in a monthly case conference. Many community behavioral health organizations have memorandums of understanding with other agencies that dictate how frequently the different parties will get together and communicate. Regardless, if there's a single point of contact, then Jane over in case management can call Sally over in mental health counseling if Jim Bob shows up and needs more assistance. That single point of contact is vital. And the integrated summary can also recommend post-treatment services. After the person progresses through initial treatment, where do they want to go? What services would be most helpful? Assessors need to be trained in psychological assessment, substance abuse assessment, developmental psychology, and the use of standardized tools. Now, many agencies don't have the luxury of using many standardized tools, but the first three are extremely important: psych assessment, substance abuse assessment, and developmental psychology. Legal issues. Federal confidentiality regulations really spell out what you can and can't say. And they are much stricter for substance abuse treatment than the regulations are for mental health treatment. Disclosure without the adolescent's consent is possible in situations such as medical emergencies, child abuse reports, program evaluations, and communications among staff. Programs may not communicate with the parents of an adolescent unless they get the adolescent's written consent. The federal regulations contain an exception for permitting a program director to communicate with the adolescent's parents without her consent when the adolescent is applying for services, the program director believes the adolescent does not have the capacity to decide, and the program director believes the disclosure is necessary due to a substantial threat to the life or well-being of the adolescent or someone else. These are guidelines that were written that are pretty general nationwide. It is extremely important that you not use these particular slides as the be-all, end-all of legal advice. Always seek legal counsel if you are unsure whether you can or should communicate with an adolescent's parents. Other exceptions to communicating with the adolescent's parents include information that does not reveal the client as having a substance use disorder, information ordered by the court after a hearing, medical emergencies, information regarding crimes on a program premises or against program personnel, and information shared with an outside agency that provides services to the adolescent. Now, HIPAA has tightened that up a little bit. For example, if you're making referrals to an outside agency, most programs interpret HIPAA regulations to indicate that the adolescent will need to sign a waiver, a release of information, for any referrals that you make. Again, consult with your legal counsel before breaking confidentiality. Other exceptions include information discussed among people within the program. So if Counselor A goes and talks to Counselor B about it, there doesn't need to necessarily be a release of information. Additionally, information disclosed to researchers, auditors, and evaluators with appropriate institutional review board review and approval to ensure the protection of program participants. So if your agency is CARF accredited or JCO accredited, for example, you're going to have reviewers come. If you receive money from the state, you're going to have reviewers come that are going to pore through your case files and look at your documentation and try to make sure that adequate services are being provided. And you do not need a release to provide those people the case files. Again, consult with legal counsel if you have any concern or doubt. Working with the Department of Juvenile Justice, there are a lot of kids in DJJ who have experienced physical or sexual abuse, who have psychological and emotional problems, who have poor performance in school. Well, if you're being abused or if you've got psychological or emotional problems, you're probably not doing so hot in school. There's family difficulties. Okay, well, let's think about this. If you have psychological or emotional problems, or you're being abused and you're having difficulty in your family environment, again, probably not going to do so well in school. Gang-related violence and involvement is another issue that's important to be aware of when working with adolescents. And living in neighborhoods where poverty and low income have led to community-wide despair and hopelessness. Some things you need to be aware of when we go back to gangs for a minute is that there are certain nonverbals, certain verbals, certain methods of dress that can incite rival gangs. Therefore, it's important to work with your local law enforcement agency to be aware of what gangs are active in your area and what things you need to be aware of that could incite gang rivalry or gang violence among your participants. Adolescents aren't little adults. It's important to remember that drug and alcohol use stems from different causes. Many adolescents have trouble anticipating the consequences of use, and treatment must address cognitive, emotional, physical, social, and moral development, remembering that much of the development in every single one of these areas is hampered or thwarted at the point the substance abuse really kicks in, because the focus turns away from all those other areas of development and their world starts to revolve around the substance, procuring the substance, using the substance, and recovering from the substance. It's important to take into account gender, ethnicity, disability status, stage of readiness to change, and cultural background. Identify and treat delays in normal cognitive and social emotional development associated with substance use during adolescence. So what types of things are we talking about? Communication skills, coping skills, appropriate boundaries and interpersonal skills. A lot of adolescents who end up in treatment tend to have overly sexualized behavior. A lot of adolescents who've lived on the street have anger management problems, tend to communicate in ways that are inappropriate at any stage. So therapy is a place where we can help them learn how to use their words instead of their bodies to get what they want, how to set boundaries, how to develop healthy relationships, how to problem solve, and how to cope with stress in healthy, productive ways. Sometimes you don't want to involve the adolescent's family because it may be the family that is the root of the problem. Sometimes you do want to involve the family because it may be the root of the problem. If you can help the family change, but if the family is resistant, if the family is insistent that it's not them, it's the child, that may be counterproductive, at least in early stages of treatment. If you involve the adolescent's family, again, with the adolescent's consent, they do have the ability to change the youth's environment to make it more supportive and constructive. There are many families out there who are willing to do what needs to be done. And it's important to be sensitive to motivational barriers. The adolescent has to be motivated to change for themselves. They're not going to be motivated to change for mom or for dad. Now, some are going to be motivated to change for the fleeting love interest. But as that love interest comes and goes, the motivation comes and goes. Know what your client's motivations are and help them maintain motivation and increase internal motivation for positive change. In treatment planning, you're going to identify and rank the biopsychosocial areas that need to be addressed. Identify attainable goals for those issues. Enhance strengths and resources to meet those goals. Don't take away a bunch of problems, because if you don't add new things, if you only take things away, the adolescent doesn't have new behaviors to take the old behavior's place. So use competing responses. Instead of putting your fist through the wall, you can do X, Y, and Z. You can go for a run. You can call your sponsor. You can go to the community center and you can go run on the track. You can play tennis, basketball, whatever. Give them reasonable alternatives to their inappropriate behaviors. Specify observable, measurable objectives and describe the interventions needed to achieve the objectives. So if one of the adolescent's goals is developing healthy anger management techniques, then they will need to identify what makes them angry. They'll need to learn about the fight or flight process. They'll need to learn how to cope with the initial adrenaline rush. And they'll need to know how it works best for them to deal with the stressors on a short and long-term basis. Program components always need to include orientation, daily scheduled activities. Now, if you've got a group home, some activities need to be on-site, some need to be off-site. If you're dealing with adolescents in day treatment, then obviously, or outpatient treatment, then obviously you've already got on-site and off-site activities. It's helpful, even for outpatient clients, to provide them with a pretty structured schedule, which reduces the amount of time that they have to make impulsive decisions. Implement peer monitoring. If you've got a group home, this is especially true, or in intensive outpatient treatment, even in outpatient treatment, in group, peers can identify issues that they may see in one another. Teach conflict resolution and link them with vocational training resources. Program levels are the same pretty much regardless of where you go. There's detox, outpatient, which is like once a week, intensive outpatient, which is several hours per week, usually several days per week. Group home residential, not medically monitored, but still residential. Inpatient hospital-based care, and continuing care. 12 steps can be used in adolescent treatment, but you want to bear the following in mind. Most of your adolescents, as well as most of your adults, have co-occurring disorders. And co-occurring disorders, CODIs for short, are primary multifaceted illnesses that exist in people of all ages, including adolescents. What does that mean? That means you don't put the substance abuse as primary and the depression as the secondary diagnosis. They are both primary. And there may be multiple primary diagnoses. Prepare yourself. Because of the way things interact, it may be impossible to ferret out from several diagnoses which one or two are the most important, because they all may have impressive significance. Persons with co-occurring disorders share a common problem, but have unique and separate needs. So don't treat all people with co-occurring disorders the same. Don't just throw them into a co-occurring disorder group and go, have fun. Once adolescents are informed in an understandable way, they are capable of helping others with guidance. Don't give them all kinds of jargon. Tell them in an understandable way what's going on, what their options are, and what they can do in order to reach their ultimate goals. Have them help others. The best way to learn something is to teach it. So have them help others learn skills that they've already been taught. Use of group therapy is well suited to adolescents who tend to rely heavily on peer examples and approval. The caveats to that are, number one, confidentiality can be an issue, and if you've got heavy gang activity in your community, you may end up with people in rival gangs in treatment. The principles of recovery outlined by AANA provide effective and proactive tools for continuing recovery. And it's important to remember that once a person has lost control over his use of substances as an adolescent, returning to responsible and legal use as an adult may require additional help and support. Most of us who come from a 12-step treatment facility background would say once you've lost control of use, regardless of age, you probably can't return to use. There's a significant set of people who would disagree with that. But I will put that out there that you don't want to tell the adolescent in the beginning, well, now that you abuse alcohol, you're never going to be able to drink alcohol as an adult. That'll blow their mind. Take it one day at a time. Adolescents need to focus on the first 5 steps during treatment. Step 1, admitted powerlessness over alcohol, that their lives have become unmanageable. Assist them in reviewing their substance abuse history and associating it with harmful consequences. Further, help them identify the positive consequences and alternate healthy ways of achieving those same ends. Step 2, we came to believe that a power greater than ourselves could restore us to sanity. Especially with adolescents with co-occurring disorders, they need to understand that this refers to helping them stop drug use and drug-seeking behavior. If they have schizophrenia, a power greater than themselves is not going to take away the schizophrenia. Important key point for adults and adolescents to realize. Step 3, we made a decision to turn our will and our lives over to the care of God as we understood Him. You may choose to use the phrase helping power instead of higher power, and good orderly direction instead of God. Good orderly direction means looking at where I want to go and evaluating whether my current behaviors keep me on that path, keep my life going in the right direction. Step 4, we made a searching and fearless moral inventory of ourselves. And step 5, we admitted to God, to ourselves, and to another human being the exact nature of our wrongs. Step 4 and 5 provide an opportunity to be accepted by another person in spite of their past behaviors, and to take a personal inventory of those past behaviors. This gives adolescents a chance to say, yeah, you know what, I've screwed up, but I can do better. It gives them a chance to make amends. It gives them a chance to start anew once they take their inventory and figure out what needs to be fixed. It also provides them an opportunity to admit their wrongs and be in an environment in which they are not rejected for not being perfect. Staff always needs training. Staff need to be trained in treatment approaches specific to adolescents and their families, in family dynamics and family therapy, in adolescent growth and development issues, and I'll add to that, staying abreast of current issues in adolescent culture. Who are their pop idols? What are the trends? What is greatly influencing adolescents at this time? If you don't understand their world, you're going to have a real hard time communicating with them in a meaningful way. Sexual and physical abuse issues, gender identity, and sexual orientation issues, mental health problems, and how they present in adolescence, because the presentation of many mental health issues is different in adolescents than it is in adults. Further, the treatment for mental health issues, especially psychopharmacological treatment for those issues, often is greatly different for adolescents than for adults. Understand different cultural and ethnic values that may impact the way you interact with certain adolescents. Understand psychopharmacology. Please know your referral and community resources. Even if United Way Information and Referral is the only number you know, at least know that one. It's vitally important to treat the client as a whole human being and make sure they have access to wraparound services, even if your agency doesn't provide those services per se. Understand cognitive impairments. Understand legal matters. Help identify, learn about different recreational and pro-social activities that are available for adolescents in your community and online. Many adolescents really like to be online. And if you can help them do that in a safe, pro-social way, then that's a good thing. Understand group dynamics and group therapy, indications of suicidal behavior, causes and symptoms of grief and loss in the adolescent, and how to manage oppositional and violent behavior. Work with your attorney to understand confidentiality issues, reporting issues, custody and juvenile justice concerns, and duty to warn issues. It's always good to work together on treatment planning and documentation. Now, at a certain point, you know how to write a treatment plan. But my staff always found it helpful during staff meetings. Once a week, a counselor would present one or two tools from their grab bag that they found especially effective with a certain population or a certain disorder. And they would announce it, they would teach it to the rest of us. We all have different tools in our little mental health and substance abuse treatment toolbox. And by sharing our knowledge and sharing our information, we can broaden each other's horizons. Train on HIV and AIDS, STDs. Again, work with your local law enforcement agency to get training on gang activity, drug dealing, and any other issues that may impact the adolescents that you're working with. Treating adolescents requires special skills and training. Most adolescents begin use in order to cope or receive external validation. They want peer approval. Adolescents' development is often thwarted at the point of substance abuse initiation. And a strengths-based motivational approach works well with older adolescents to help them develop into healthy, proactive, prosocial adults.